Dr. Maelo is a medical officer in charge of Naitiri, I believe, health center or medical clinic in Bungoma County. Dr. Maelo is a lab professional who may inspire each one of us. He started as a diploma holder, and at the moment, he has his PhD in medical lab. He has specialty in forensic medicine, microbiology, and tropical infectious diseases. So this evening, Dr. Maelo will take us through COVID-19 current situations, the lessons learned, and the laboratory preparedness for other outbreaks. Dr. Maelo, are you able to hear us?
Yes, please. Thank you, Bruce.
Welcome, Dr. Maelo. The mic is yours.
Thank you, Mr. Bruce. Welcome, colleagues. It's a great honor to have you in this webinar. As the moderator has said, today I'm going to take you through COVID-19 current situation, lessons learned, and laboratory preparedness for other outbreaks. Next slide, please. Objectives. At the end of this session, participants should describe the emerging respiratory viruses, comprehend the current global, regional, and the local situation, analysis of the local coronavirus outbreak, overview of the infection prevention, case definition, and the process in terms of sample collection. Next slide. Okay, before I talk of the background, allow me to make a simple definition of COVID-19. COVID-19 is the disease caused by a coronavirus called SARS-CoV-2. Coronavirus belongs to a large family of viruses that cause respiratory illness that belongs to the coronavirus. It was first isolated in the 1960s. It circulates among animals, that's the avian, most notably birds and human, that's zoonotic. Next slide. Emerging respiratory viruses. Over the years, viruses continue to emerge and pose challenges to public health. Some of the examples of emerging respiratory viruses include, like in the 2002, we had SARS-CoV. Then in 2009, we had H1N1 influenza. 2012, Middle East respiratory syndrome corona. The virus is called MERS-CoV. Then 2019, that is the novel coronavirus. Novel stands for new. Next. In 2019, it was first identified in Wuhan, China in 2019. The initial case was linked to Wuhan seafood market in Wuhan City, China. The market was closed on 1st of January 2020 for environmental sanitation and disinfection. On 10th, just a minute, on 10th, the WHO launched the website. I think this is for your information. Next. This is the accumulative numbers as of the time when the tracker was being updated. But I want to comment that as of April 2013, 2024, the coronavirus tracker is no longer being updated due to the infeasibility of providing statistically valid global totals. But as it goes with my title, the main focus is the update, so called the next slide. So the latest update as on the last 28-day period, that is from June 2025 to 13 of July 2025, 90 countries across 5 WHO regions reported new COVID cases. During this period, 122,852 new cases were reported. which is a decrease compared to 396,078 new cases reported from 95 countries in the previous 28 period. That is, table 2 is in the subsequent table. The overall 39 countries from Africa, Americas, that is South and Northern America, Europe, and Southeast Asia, showed an increase in new cases over 10%. Next slide. So this is the explanation. You realize that worldwide, I was talked of 396 on 15th of June and 122 as of 13 July 2025. But our focus is Africa. In Africa, there is what was reported previous was 285 and currently 319. So that's the current update as of 13th July 2025. Next slide. So this is the cumulative total for Kenya. Ever since the first case was reported, total deaths 59 and total recoveries 33709. But as we realize, looking at this graph here, we realize that we have had a little bit of inconsistencies in surveillance for over the last 3 years. And you realize that from 2024 to date, the graph is flattening. It's not that we don't have a case, but the surveillance has gone down. Next. So this slide highlights the role of laboratory in outbreak control. So our main role, among other roles, is to detect, confirm, screen, and determine exposure to the pathogen. Next slide. These laboratories for investigation, we have the human, the county sub-county laboratories, the national reference laboratories, research labs, animal and environmental, veterinary laboratories. As in Kenya, we have Kapete, then research, national reference laboratories, that is food, underwater, and then government chemists, and division of vector-borne. But of importance to realize among these research labs, we have worldwide, we have 15 laboratories. An example is the Center for Disease Control USA. And then we have Wuhan University. And this one is one of those studies globally, but now the focus will be here locally in Kenya. Next. Next slide, please. Okay, now this is the case definition. I will not dwell much on this, but this one is that is the criteria for screening COVID-19. It's conventional known that the temperature was a focus that's greater than 38 degrees centigrade within the last 14 days. And it was based on history of travel and also the close contact. And you have to realize that we do what we call contact tracing. Contact tracing is a matter of, just a process of identifying and assessing that the patient or someone is at risk of COVID-19, and which I have not captured in this slide. You have to master the 3 C's. The first C is crowding. If you have the crowd, when you have a crowd, is one of the risk factor. Then close contact, and then confined places where we have minimal ventilation. I think we can go to the next slide. I was just giving an explanation on the same. Next slide, please. So basically, allow me to talk about the infection prevention. Why is IPC important? This is what to note. That it reduces the transmission of COVID-19. It enhances the safety of healthcare workers, patients, and even the communities, enhance the ability of the organizational health facility, to respond to the COVID-19 pandemic. Next. Next, please. Yes, so this is just a continuation of the same. So let's go to the next slide. It's just talking the same. Let's go to the next slide, please. So this is the IPC practices of importance: hand hygiene, proper use of PPE, self-injection practices, cleaning and disinfection, and then respiratory hygiene and cough etiquette. Next. Now, this is where the rubber meets the road. Our main focus as laboratory science is sample management of COVID-19. So this is the criteria for testing of COVID-19 patients. The patients meets clinical and risk criteria for a patient under investigation, the one that I had just highlighted before. High priority, talk of hospitalized patients, the healthcare workers, and the resident and detection facilities. Priority community surveillance, I think, which is now, which I talked of now, we have inconsistency on the same. Next slide. Specimen collection, perform the following: proper infection control, use recommended personal protective equipment, N95 for a higher level respirator, that is the face mask if a respirator is not available, then eye protection, gloves, and gown. Next. So this is just a prepared specimen, but my main focus will be on nasopharyngeal and oropharyngeal. That is from upper respiratory infection, which I've highlighted. But we also have other samples like blood, depending on what you want to detect, like the nasopharyngeal and oropharyngeal is for antigen detection. But if you want to detect like the antibodies from someone, then you have to go for serum, which is now separated blood. Next. I think this is just on the choice. I will not repeat it. Next. Next slide. Timeline for sample collection. Collect as soon as possible after symptoms begin. That's ideal within 7 days before the antiviral medication is administered. And you will see from this graph, that is the first 7 days is when the virus is shedding. But if you collect after that, it's antibody response will not get the meaningful result. Next. This is now this is what you require in specimen collection. The PPEs have been highlighted, the protective clothing, and so on. That is for your consumption. Next slide, please.
Excuse me, Daktari.
Yes, please.
Yeah, for the sake of, I can see for the sake of 1,200 attendees present,
yeah.
One of them has requested that we go slow. We are too fast.
Okay. Thank you.
Thank you so much, Daktari.
Oh, wow, that's great. So preparing nasopharyngeal, and this NP is for nasopharyngeal swab, and the OP is oropharyngeal specimen collection. So PPE needed, you require gloves, masks, goggles, then protective clothing, you require facial tissues for patient use, a cooler container with cold that's ice pack and biohazard label. Next, I hope I'm now not so fast. Then preparing for nasopharyngeal and oropharyngeal specimen. Supplies needed, you require the cryovial with viral transport media. That is the VTM, not containing any antibiotic. Then 1 rayon tipped swabs, aluminum shaft for nasopharyngeal swab. Then 1 dragon tipped swab, flexible for oropharyngeal swab. You also require one tongue depressor, headlamp, optional but strongly encouraged. This is the one that will help you visualize the nose or visualize even the oral cavity when you are collecting the sample. That is mouth. Out. Then permanent fine-tipped soap. Require soap. Just a minute. You also require, I will talk of on this other side is soap and water, sterile scissors, paper towels, specimen lappers, biohazard bags for disposal, 10% bleach, then data collection form. Next. Okay, now these are the swabs of choice, the specifications that we have the locked swab and the rayon swab. Let's go to the next. Specimen collection containers. We have the universal, and that's VTM, which I had just mentioned, viral tube material VTM. Next. This is a specimen collection overview. And this one, my main focus is nasopharyngeal. And then we have the oropharyngeal. And of importance to note is that for you to know how deeper you have to go when collecting the nasopharyngeal swab, you have to measure the distance between the nostril and the ear. That is how far you have to go. Next. Now this is the real procedure. Oropharyngeal swab, you insert swab into the posterior pharynx and the tonsillar areas. Wrap swab over both tonsillar pillars and the posterior oropharynx and avoid touching the tongue, teeth, and the gums. Then nasopharyngeal swab view. The nasopharyngeal, you insert the flexible wire shaft through the nares parallel to the pellet, not upwards, and resist. Is encountered or to the nostril, which I've just mentioned. You have to leave the swab for some time to absorb before you remove it. Then on specimen, the patient's name, the patient ID number, specimen type, and then date collected. Next. Now the laboratory requisition, what we call the case investigation form. I think you have to capture the information that I've mentioned, but the patient information is very key. And not forgetting the name and the phone number of the physician who requested. Then this is the case investigation form that I've just talked about. I think you can project it for people to review. The information that I've captured. Go to the next slide. Next slide, please. Okay, now storage of specimen. This specimen must be kept cool. That is, if transported within less than or equal to 72 hours, you keep at 2 to 8 but if delay is unavoidable, that is greater than 72 hours, you keep at -degree centigrade. That is shipped on dry ice. Next. Now this is packaging. In packaging of the COVID-19 or any other sample for outbreak, you require triple packaging. It uses 3 packaging layers. The first layer should be watertight. Use absorbent material in all layers. Like we have the first primary container with absorbent packaging material. It also holds the specimen and it has the cap. Then we have the secondary container. That is the one that holds the primary container. It has the specimen record. This one, it has a biohazard label and the address label. Then sample referral process. One, we have the patients may walk to the facility. You may capture the patients at facility level, or you may get samples from peripheral sites or from from the spoke sites to the hub. Then, or you may also get the samples that is at the testing hub. That's the laboratory where the test is done. Then the chain continues. Next slide, please. These are the models in use, the one that I've just highlighted, depending on where we like. We may have writers, we may have FIDEX DHL. That is for samples that are transported outside the country. Then we have the national post system, and then we have the public transport system, and then the G4S. And then we have the specimen transport system, that's the motorcycles, vehicles, ambulances, or cough monitors. Then use of ambulances to transport samples, that is from clinical outreach. We have clinical outreach teams and the CHVs. Next. Lessons learned. Economic impact of COVID-19. We realize COVID-19 has caused us to reset the way we operate our systems. There was closure of schools, training institutions, and the churches, closure of businesses, partial and a total lockdown. There was curfew, temporary waiver for those who were in the system as of the year 2021, when the spike was high. Those who are earning less than 24,000 Kenya shillings had 100% waiver, and those earning more had a waiver of 30 to 25%. And it also, another economic impact is that it caused the job losses of more than 3 million. And also it led to discouraging public gathering, private gathering, the likes of churches and so on. And also banning of sports. For those of us who are a fan for the sport, it was a little bit of challenge to deny you fan. Next. The government, we want to appreciate the government of Kenya through the Ministry of Health. They use this, they have now come in place, they have now initiated continuous hand washing and sanitation, continuous use of masks in public places. Though this one, I want to believe many people were fearing the directive from CS Mutai Kakwe as opposed to person. I can observe that nowadays majority of people do not use the masks in public places. Then there was fumigation of public places, hospitals and the markets. I think it was well done. Constitution of multi-agent teams, the rapid response teams and surveillance teams was put in place. Training and sensitization of healthcare workers was done, and it's ongoing. Targeted mass COVID testing was done. Then establishment of quarantine, isolation, and the treatment centers. Before you ask a question, maybe someone will ask, what is the difference between quarantine and isolation centers? For quarantine centers, you are separating the conducts of COVID-19, but isolation, you are separation of patients. That is the health under the sick. And then observation of physical and the social distance is one of the mechanisms. Research has shown that COVID-19 is primarily caused by, that is the respiration droplets and the contact. So if you keep at this distance of 1.5, then you protect such as effective hand washing and a physical economic burden. Okay, what is being done to control the outbreak? Remaining, we remain vigilant for new cases and providing care for the existing care. That is now what is being at the WHO level and even at national level. Implementing screening of travelers. So for COVID-19, it is not done as it was done when there was a pandemic. I think it is suboptimal. Sharing information with WHO and other countries, this one is ongoing. What is WHO doing? That is supporting affected countries and providing guidance on how to manage the outbreak. Then working with global networks of research and experts to deliver accurate, updated information, delivering accurate and timely information to the world. This is true. You realize we have the, we have the reference which I'm about to share with you. We have the WHO website that was launched, and we have the COVID-19 the COVID-19 network that has been launched in the newsletter. If you go live to the reference of WHO, you will find it from the COVID-19 tracker. Next slide, please. This is take-home message. Successful diagnosis depends on quality of specimen collection, type of specimen collected, and specimen transport and storage before it is processed in the laboratory. That is specimen collection, laboratory testing, and diagnosis. There is that link. This is the references. So I want to thank everyone who participated in this collaborative effort. Over to you, our moderator.
Thank you so much, Daktari, for that elaborate presentation on COVID-19. Indeed, it's something that just came. It's novel to us, the same way you said. It was a new virus to us. And scientists had to come up with ways of how to prevent, how to control it, the vaccines, and even on the preparedness whenever such outbreaks come. So thank you for that. I think we are now going straight to the question and answer session. And I encourage members, you can always ask your question on the Q&A. So maybe I can start with Ngeno Peter. Ngeno Peter is asking, explain the molecular mechanism by which SARS-CoV, according to Ngeno Peter, explain the molecular mechanism by which SARS-CoV-2 enters human cells and how this process can be targeted pharmacologically.
Okay, explain the molecular mechanism.
Explain the molecular mechanism by which SARS-CoV-2 enters human cells and how this process can be targeted pharmacologically.
Okay, thank you. Just capturing the questions.
Yeah, you can take that up before we proceed to the next question.
Okay. So that question can better be answered. We have the molecular mechanism, that is, we normally use the PCR as the molecular test that is used to detect the COVID-19. And now pharmacologically, it means that first of all, we have the normally have the DNA sequencing to get the variance. That is the variant. Now from detection of the variance, then we shall now know the tracker of choice for the SEM. Thank you. Another question?
Thank you so much, Daktari. I also encourage members to, you can also raise your hand so that we can give you the mic and ask your question. Sami Gishoi saying loud and clear, thank you. Benedict Wachala is asking, based on the emergency of new diseases in the world as a country, based on the emergency of new diseases in the world as a country, how prepared are we? Because like the COVID-19 case, we relied on external help to combat through donations, and the help of WHO is there. Is there a budget for emerging diseases? And if so, how much for this year? Thank you. That is a question from Benedict Washara. I don't know, are you in a position to answer that, Daktari?
Okay, that's a very good question. However, it is slightly outside my presentation. However, this one I will have to consult further sources on the budget that has been put on the SEM. Maybe if I went further to check on the budget that has been set aside on the SEM. Thank you.
Thank you. Kennedy Achila is asking, are we ready to respond to Mpox?
To Mpox? Okay, though it's a different one, but I think we are ready for it. Like as we are talking, we had a case of Mpox that is in Trans Nzoia County, and as the Ministry of Health, already the mechanisms that have been put in place, but our main role as laboratory science, there is an SOP for sample collection, and also we have a role to play, as I had highlighted. We have a role to screen, detect, and also participate in that conduct tracing and the sample collection, and then sample referral. So there is something that the ministry is doing, as is in the case of Mpox case that has been reported in the Trans Nzoia County.
Thank you so much. Alvin Kinji is asking, what is the basis for not having antibiotics in the transport media? Yes, Daktari, what is the basis for not having antibiotics in the transport media?
That basis of having antibiotics in transport media, you realize that the viruses do not respond to antibiotics, but now the antibiotic is meant to, antibiotic, as the name suggests, it is antibacterial, so it kills bacteria, but it does not kill the viruses. So it's important to keep away bacteria from the transport media. Thank you.
Alvin Kinji, I hope the answer is elaborate for you. But if you have more question or you need further clarification, or you can comment on it, you can raise your hand so that we can give you the mic, Alvin. Another question is from Abisai Angira. Abisai is asking, which measures have you put in place to detect and cleared coronavirus cases? Which measures have you put in place to detect and cleared coronavirus cases? Daktari?
So, and for which measures that have been put to detect and clear coronavirus
Cases.
measure. So the measures that are there, that is the gap we have, as I had highlighted, from the year 2022 to date, there has been inconsistency in surveillance. And it's my role, it is me and you, the colleague has asked to do surveillance. Maybe from the definition of surveillance is the ongoing systematic collection of data for decision making. And decision making, I mean collection, organization, summarizing and presentation, and analyzing of data. That one is through that we can really know that we have this is uncleared COVID-19 case. But as you all know, it is both at the WHO and the national level. There was a vaccination. Through vaccination, now the vaccination is a way of herd immunity. And the herd immunity is through the WHO uses vaccines. And what the vaccine does is they treat the immune system they teach the immune system to produce antibodies to fight the disease. Thank you.
Thank you so much. A question from Kaya Metcalf. That's a difficult name, huh? Kaya is asking, Kaya, you may forgive me if I'm pronouncing it wrongly. Kaya is asking, why were African countries, despite limited resources, less affected in early stages compared to wealthier nations? Why were African countries, despite limited resources, less affected in early stages compared to wealthier nations? And you can also combine it with the Adnan Makoha question, which is how is the current prevalence of corona? Over to you, Daktari.
Okay, the current prevalence. I think if you could go back to the slide that I had, but for the why we are saying African countries were less affected, that is theoretical, but we have to speak with data. I think the issue was not that African were less affected, but it was because of the reporting way. Maybe it was I've just given it out that I talked of the COVID tracker currently not being updated, but from the epidemiological, we have the weekly epidemiological data that is currently being done by the WHO, and this is as of June, I had highlighted. This is what we have projected. We have that is the current prevalence. Now, like the prevalence, I think if you go to WHO website, you realize that it is at 4% in Africa, but in Kenya, it has not been reported, so we cannot really tell. We need to do surveillance to ascertain the current prevalence currently in Kenya because of inconsistency in surveillance. Thank you.
Thank you so much. Alvin Kinji is asking again, does the Ministry of Health proactively carry out COVID-19 surveillance considering the pandemic is over? Let me come up with the question again. Does the Ministry of Health proactively carry out COVID-19 surveillance considering the pandemic is over? Daktari?
I think that's similar to what I've said. The challenge we have as a country, the surveillance, we have had consistency. I know it is being done, yes, but we have consistency in surveillance. That is from the year 2022 to that over the last 3 years. That's now from the graph. I think you can show him the graph that I had projected for Kenya. You find that it is showing that it is flattening. It's flattening, meaning that there's no case. But if there could be no case, ideally is that we may be having cases, but the cases are not being reported. So we need to do surveillance so that to establish and ascertain whether the cases are, we have the cases or we don't have the cases.
Thank you so much, Daktari. As scientists, I believe these are some of the gaps that we can always come in and see if we can cover them, back them up with our scientific information, and probably publish them. So that's if we can also answer Naftali Dugan. Naftali Dugan is saying, can we as a country, can we say as a country that we are COVID-19 free? Naftali is asking Daktari, can we say as a country that we are COVID-19 free?
The answer is no, because we have inconsistency in surveillance. Unless we up the game on surveillance, it's when we can say ideally that it is no. As much as we have had intervention of vaccination, which have said that vaccination promotes herd immunity. Under the herd immunity, the vaccines, they treat the immune system to produce the antibodies. That's the scientific explanation. They produce antibodies that keep away the disease.
Thank you. There are actually several questions. They are revolving around the same thing. Tibet Gideon is asking, is in COVID-19 diagnosis, is there staging and detection of the virus variants, or is it just positive and negative diagnosis?
Okay, I had also explained, but I think I want to give you the reference where you will get. If you go to the web, on this WHO, you just say COVID-19 situation report. Then on the situation report, you will go to epidemiological. That is epidemiological weekly data. Then you will see we have all those events. So the variant is not only about staging, but we have the variants. Like we have, it is called the XFG. XFQ is the variant that is 49%. That is the current that looks that is really affecting people worldwide. But we have other variants you will find there, but this is the variant of choice. Thank you.
Thank you, Daktari. I think I'll just go to technical questions that are really affecting us as the lab. I'll go to Wycliffe Mbadi. Wycliffe Mbadi is asking, for how long should specimen, both NPS and oropharyngeal, stay in VTM before processing?
Okay, that one, it was on that slide that I said that you have to transport the specimen that is in less than or equal to 72 hours. That is at 2 to 4 degrees centigrade. But if delay is unavoidable, I said you have to keep at negative. So within that time, you have to, that's the timeline that you are supposed to process the sample, or else you will not get the viable result. Thank you.
Thank you so much, Daktari. I said we go technical questions that are really affecting us directly. Austin Okola is asking, how are you sure? Okay, he's asking, how do you ensure that all diagnostic test kits are available and affordable within our local suppliers?
How do we ensure
that all diagnostic kits are available and affordable and within within our local suppliers?
So this question is a good question. However, it revolves around we have you as the labs, and it depends now at the level that in that small capacity and big capacity, we normally have the allocation. When you do allocation, you not only allocate the commodity for COVID-19, but we also have commodities where, like for COVID-19, I know we need to have what we call contingent plan. But for other commodities, we normally have what we call allocation. Just like HIV, we normally have the quarterly allocation for the commodities. And also through apart from the allocation, you also need to capture in AWP. We normally have what we call the annual worker plan, so that from the worker plan you can have support either at the facility level, at the county level, or from the partner who can give you funding for the commodities. But this one for the outbreak, I think it is the mandate of the MOH that takes lead in mobilizing the resources for supply of these essential commodities. Thank you.
Thank you so much. Another question from Calvin Owino. Calvin Owino is asking, what innovations were born out of the pandemic, and which ones should be retained and scaled in our healthcare?
Okay, let me answer you very well. Just wherever you are, I think it's Calvin Owino, write the word Wuhan in a vertical way, and I will answer you. So the W, that is wash hands properly. That's one of the initiatives that you cannot do away with. Then U, that is use masks properly. That is also what is not being done, but if we continue with it, it is a best practice that can help us keep away pandemic. Then H, that have temperature checked regularly. Then A, for avoid overcrowding. I told you there were 3 predisposing factors that predisposes you to COVID-19. That's the overcrowding. I said there was also that is close contact, and I also talked of the confinement. So that is the 3 C's. So you have to avoid the 3 C's. Then lastly is N for never touch men. And the men is not male gender per se. Men, the M stands for that, never touch mouth, eyes, and nose. I hope I've taught you something. That's it.
Thank you. Thank you for the word, for the answer. Okay. Baraza Johnson is asking, what can be the sample of choice for COVID diagnosis? I heard stool can also be used for diagnosis. Daktari, maybe you can clarify that.
Okay, sample of choice. Okay, there are so many samples. I think stool, the one for stool was not mentioned by me. It is under research. Perhaps you pilot it and you publish so that you can come and share with us. But from my presentation, the sample of choice is nasopharyngeal swab and oropharyngeal swab. And that is when you are detecting the antigen. This one can be both either by PCR or by the rapid antigen tests which are to detect the antigens. But for the antibodies, you go for blood where you separate serum. Serum is for antibody detection. But for stool, that one I have a reservation. But it's a very good subject under research. Thank you.
Thank you so much. Okay. This one is not related to today's topic. And our speaker, you don't have to ask to answer it, but it's also open for discussion. Robert Koros is asking, last week we had a client who we tested and was HIV negative last week we had a client who we tested and was HIV negative, though he was under ARVs. On inquiry, she said she has used herbal medicines. Is it possible for such cases? If yes, has anyone come across? Thank you. So that is subject to discussion, Robert Koros. Unless the speaker, you want to comment on it?
I think that one, it is true. It is not within my jurisdiction of my topic, but as Sandis, I think, but when you say that he tested HIV negative, maybe I want to also to pose a question to him, which method did you use? Because normally, when you use the normal HIV kits, that one, you are just antibody detection. But if you went further to have like an advanced test, maybe you could ascertain if the person was indeed HIV, because a person is when someone is on HEART, that is highly active and retroviral therapy. If you test that person with the HIV kit, automatically it will test negative, but it does not rule out the chances of being HIV negative. That is my attempt, but I think the panelists and other panelists who are here can also assist in addressing the concern. Thank you.
Thank you so much, Daktari. We are almost coming to the close of the webinar. Maybe I can take two more questions. One is from David Ombachi. David is asking, how did misinformation affect public response to COVID-19? How did misinformation affect public response to COVID-19?
To COVID-19. So how did misinformation affect public response to COVID-19? I think when we had the first case reported in Kenya, instead of combating the COVID-19, we health workers, the frontline workers, instead we were running away, because we knew that if someone will, because of if someone will cough, automatically it will the droplet will land on you, then you will contract. So we had it, there was fear. That is what happened. But after it was discovered that when you do that there's no harm once you use the IPC. That's why I talked of the IPC is very key. Once you have the IPC, you can handle a pandemic of any nature. Thank you.
Thank you so much. I want to give a few attendees the chance to ask their questions or give their comments. I can see 4 people have raised their hands. I can start with Magdalene Nkirote. Magdalene, if you can hear us, you can ask your question. Unmute and ask your question, Magdalene Nkirote. Okay. Maybe it was by mistake. Collins Onyango, you can unmute and speak. Collins, you can unmute and speak. Okay, it was by mistake. Lillian Nyaboke, you can unmute and speak.
Ole.
Okay. It was by mistake. Fred Mose, you can unmute and speak.
Okay, good evening.
Good evening to you, Mose.
Can you hear me?
Yes, we can hear you.
Yes, mine is to congratulate our presenter today. And actually, I came to realize that with the laboratory technologists in our facilities, we are the chair of IPC. So having learned new techniques from our presenter today, I think we are going to implement some of the practices he has taught us and actually improve our service delivery in our facilities. Thank you very much, our presenter.
Thank you so much, Mose.
Yes.
Let me give the chance to Collins Wafula. Collins, you can unmute and speak.
All.
Good evening to you, Collins.
Are you hearing?
Yes, we can hear you.
Okay. If I may ask about COVID, we used to test the COVID in our hospitals or in our lab, and in most cases, we testing tools used to expire, and now as we are talking, we don't have those test kits or the tools that we are supposed to use to test the COVID, and even the clinicians are not requesting for the same. So what are we going to do so that we come back to what we used to do in terms of testing or requesting for the same? And the second question, Dr. said that we have read about what is the work of WHO in COVID. One of it is to support affected countries and providing guidance on how to manage the outbreak. So my question is, if in Kenya, Dr. said that we don't have that accurate data, how are we going to benefit from the WHO as a country if we don't have that data, good data from the COVID-19? Thank you.
Dr. Maelo, are you able to take up the questions?
About the expiry of the kits, it is true. We had when it was assumed that when we had the issue of vaccination and the vaccination, so people knew that you can be protected from COVID, and now even the kits that were there now. But what we are trying to say, I'm talking of the surveillance. Still, everything is revolving about the surveillance that has been inconsistent. If at our own, from in your own local level, if you up the game for surveillance, then I know you do allocation for the commodity. You will be able to have the commodity at hand. But however, it is not only for COVID, but you have to allocate alongside other commodities. Then about the affected countries, like what I was talking, we are talking of Kenya. It is the Kenya, the surveillance. I'm not saying it is not being done. Surveillance is being done, but inconsistent. Ask yourself, apart from that time of pandemic, how often do you to conduct sample collection, conduct tracing, and surveillance in your area of jurisdiction? That's a question that should be answered by all of us. That is how to respond to that. Thank you.
Thank you so much, Daktari and Collins, for your remarks. Okay. Collins Onyango, you can unmute and speak. Collins Onyango. Okay. Abdi Burje, I saw your hands up. Okay. Alvin Kinji, you can unmute and speak. Alvin.
Good evening, everyone.
Good evening to you, Alvin.
Yeah, how are you, sir?
I'm very fine, Daktari. How are you?
Now, first of all, I want to say thank you for this magnificent presentation, which seems to be aligned to the laboratory medicine. But again, it broadens its wings into capturing infection prevention control in our hospitals. Maybe I want to pose a question to the good presenter about the sample, the nasopharyngeal and oropharyngeal samples that we used to stock during the COVID-19 pandemic. We used to stock them in negativity freezers. Maybe Dr. should tell us and clarify for how long should we continue stocking them now that the pandemic is over, or should we donate them to research farms and institutions for further research? Thank you.
Okay, thank you very much. That's a very good question. In fact, you have just answered the question indirectly. You need now, whatever as the regulator, now that I'm now talking at the KMTP level, in the laboratory, you need to have fridges and freezers for various for various functions. One is for sample archive. So if you have a fridge for sample archive, it is good. It can be used for research purposes and also for follow-up purposes of the affected patient. Then we also have other fridges like for the reagent, and for those who are in the area of blood transfusion science, they can also have the blood bank. That's for storage of blood. So it is a blood, it's a plus, and it is an area that can be improved on.
Thank you, presenter. Thank you, sir. Thank you.
Thank you so much to all of us. We've now come to the end of our webinar today. I want to take this opportunity to thank all the attendees who managed to attend. We just want to announce that this webinar is CPD accredited, and we will be able to credit the 3 points to your KMLTTB portal within 24 hours. Our next webinar will be on Wednesday, same time from 3 p.m. You can always join our WhatsApp groups for the alert, or you can visit our website and register through the LMSK Learning Hub. Otherwise, I want to give our presenter to the chance to give his final remarks. Daktari, welcome.
Thank you so much, colleagues. So I want to finish that by saying that the laboratory is the backbone of laboratory medicine. A lab scientist is an unseen hero who hides behind the curtains to demonstrate what is ailing you. You are not sick until you are tested and confirmed by an MLO. And lastly, it is our mandate to protect the autonomy of our laboratory profession. So it is high time to move out of the comfort zone and explore as laboratory science. Thank you, and God bless everyone who listened to this presentation.
Thank you so much, Daktari. And on behalf of LMSK, we say thank you for your time that you took preparing for this presentation. It is in the spirit of sharing information that we're having this webinar. And I want to beseech all of us that our work or our engagement should not be on the webinars alone. We can always engage on other forums. So, and LMSK is giving us the forum to do it. So at your convenience, you can always register and be a member of LMSK so that we can create more forums for discussion and develop this our lovely profession. Otherwise, thank you and see you on Wednesday.